So I just want to thank everyone for coming. As Dave was saying, we're going to talk about some of the case-based rounds, obviously to do with pediatrics. Won't give away too much at this point. Gurinder's going to start us off with a case, because it is case-based rounds, and then we'll go from there into a discussion about the specifics.
Okay, so, when we're coming up with a topic, and he gave Sean a bunch of different kind of cases and stuff like that, and said, okay, so which one do you think will be best? And so he decided that this would be a good review. So this has happened to me a couple of times. It's been a couple of years now since the last time, I think. You're working usually, it's probably the middle of the night, well, you guys don't do full nights anymore, I guess, but maybe you do at some of the other places you guys work. It's usually 5 o'clock in the morning, and triage, either the registration clerk, the reg clerk comes running in, or triage nurse comes running in and says, we need you out front, we have a delivery. Unfortunately at 5 a.m. there's never pizza that they're talking about. So nurse comes in running in, asks you, hey, we have a delivery in the parking lot, or a lady comes in, she's delivering. As you go outside, what are you thinking in your mind? Oops.
Okay, we can use those.
What are you going to be thinking about as you go out?
Shit.
Yeah.
This is UH too, right? So I mean,
Yeah.
you can't just go get, I'll just go get Gary or Gurinder or something down the hall. So.
What do you think? What are the things that are going to be going through your mind at this point? The first couple of things that are going through your mind.
Chris Lee, what are you thinking?
A lot of things. Mostly I don't want to be there, but probably, there's 2 patients at this point, both mom and baby. So preparing for resuscitation of both mom and baby, and also delivery, and then post-delivery, care of mother, and then care of baby. There's more care than I can provide on my own, so getting help, getting them in the right place, getting everything together that I need. There's a lot of considerations at this point.
Sure. Yeah, and you're right, so it's a matter of preparation, right? And so from the baby standpoint, what are you going to be thinking about preparing? Marcus?
So any complications that can happen delivery, intra-delivery, post-delivery, and having anybody on the phone, even if you're not at a big center, to help you with.
Okay. When you're going out, is there anything you're going to take with you? What would you take with you? Nothing? Yourself? A nurse, maybe?
3 pair of shorts.
Okay, we'll talk about all that. Okay, so you get out front, and so this happened to me when I walked out. Got out there a little bit different because the baby wasn't in mom's lap. Baby was being held below, in between mom's legs, kind of front seat of the minivan. So now what do you think?
We're good. Here we go.
Job done, check. What are your first steps here?
I want to see how baby is doing, like
Okay.
our scores or.
But you're right. How?
Is breathing
Yeah.
cyanotic, needs any immediate resuscitation.
Yeah. So first thing is going to be exactly that, right? Like, so is baby crying? Is baby vigorous? Right? Those are kind of the first couple of questions that you're going to be asking, right? Is baby doing anything at all? Okay. Then what?
Is there still a cord? Like, I'm still
Good
attached?
question.
So,
Good question. I'm going to presume mom didn't
so
let the cord.
I want to have like a suture or anyone can grab clamps or something. Would I get, separate 2 patients so we can deal with them appropriately, get baby into the hospital, and then start figuring out if mom's okay?
Yeah, no, for sure. And I think that that's kind of, highlighting an important point. So that's why, so that I was saying, what else are you going to take with you? Most, so they have it here at UH, we have it at Vic. Most emerges have a birthing tray for this type of thing, and in there you have cord clamps, scissors, the basic supplies, like towels and stuff like that. So those basic supplies you're going to need. So those are the things that you're going to be thinking as you kind of run out. Okay, I got to clamp the cord, I got to separate the 2, get baby inside, and then deal with mom. The nice thing, of course, if this happens at Vic is usually it means I'll scoop and run with baby, And when this happened, I remember there was, a nurse on the outside who was like, and Mom, I'm like, I don't know, you guys deal with her. So that's the beautiful thing about our job, hey, there we can divide and conquer. Okay, so lots of things to think about, and a lot of it comes down to, is the baby vigorous or not? Generally speaking, if this happens and there's a really precipitous delivery, usually it's because the baby is actually well, and it shouldn't be a problem, but that's not always the case. And we had one, again, a couple of years ago where baby did come out flat. I had one, I think it was 2 or 3 years ago now, where baby came, in this scenario, the baby was flat and actually needed some further resuscitation. We'll kind of move into that. And, we won't necessarily talk about all that resus right now because I want to give Doran something to talk about as well. Why don't we continue? Sean, you want to start with some physiology, I think?
Yep. So obviously, we're going to talk about some neonatal resuscitation issues, but the main one we're going to focus on is that newborn period. So this is kind of picturing the case where your UH is 5 o'clock in the morning, so you don't have double coverage, and something's going to happen out in the parking lot or in the triage desk that's going to be, oh shit, now we got to basically go back and start thinking of these things. And I think it's important for 2 reasons, right? One, you can be in this situation. Certainly, at university it can happen. It happens at Vic at least once or twice a year in the department, I think. Mind you, we have extra support there, so it makes it a little bit easier from our perspective, I think. But you can also be in smaller centers, like not all of us are going to work here. Not all of us are going to work in places where we have dedicated peds emerge. So this is something that you do need to be familiar with, and it's helpful to just go over it from time to time to sort of remind yourself about it. And then talking with Dave was kind of one of those things that was due for review sort of in the overall grand round schedule, so it seemed like a good topic to do. Another reason is the new guidelines are actually coming out fairly soon. I think within the next few weeks actually, so it's a good time to just review kind of the old ones so that if you see something different or if you see some things that you kind of haven't heard about before that are talked about, that you kind of know what's going on with that and why that they're in there. Although I don't think we really expect any huge changes in the next iteration because so much of the research is ongoing and it's inconclusive and controversial that there may be mention of some of these things that I'll discuss in a little bit, but no specific changes but probably going to come about. But look for them anyways. So the objectives of the talk, really, we're going to review some of the physiology of that sort of transitional period from the intrauterine to extrauterine environment. We're going to review basically just the neonatal resus guidelines and the algorithm. We won't go step by step through the algorithm, but I'll try and just really talk about the big key concepts that are driving what you're doing, and I think that simplifies the process if you're a little bit nervous or kind of in a bit of a panic, and it helps you focus on what's really important to make sure that you have a successful resus if you need to do that. We are going to take a look at some of the practical issues of doing this up at University Hospital specifically, and that might actually apply to other centers as well. We'll talk about some of the challenges throughout the discussion that you may run into and how to overcome them, and a little bit about how to be prepared because it's a nerve-wracking experience. I think if you break it down to its components and core concepts, it makes it a little bit easier for you if you're cognitively loaded and thinking about lots of things. It helps simplify the process for you. So the first step is a little bit about the physiology, and basically this is really sets up why we're doing the things in the newborn resuscitation that we're doing. There's lots of different ways of displaying this diagram, but essentially what it boils down to is there are 3 main shunts that are operating in the fetal circulation. You have the ductus venosus, which is down the bottom from the placenta, attaching in up around the IVC. And that provides a lot of the oxygenated blood to the fetus and is a source of significant cardiac preload for the fetus. The foramen ovale is the shunt between the RA and the left atrium, and the ductus arteriosus, which shunts from the right heart to the systemic circulation. Ultimately, what you're doing is sort of avoiding an organ that isn't really being utilized in utero, right? There's other diagrams for this. Again, with all these, the core concept to take out of this is 3 main shunts: ductus venosus, foramen ovale, and ductus arteriosus. We don't think about the ductus venosus quite as much as the other 2, but it's still kind of an important player, but it fairly early gets taken out of the picture. We have this sort of diagram, which I'm not really sure what's going on there, but when I looked through it, it's kind of like at least partially consistent with sort of neonatal physiology, and whatever helps you figure it out and understand it, go for it, right? And I think this one probably I thought was among the more useful ones. The main reason is you've got sort of the main sort of diagrammatic representation of what's sort of at play at different stages, right? So on the far left there you have the fetal circulation. At the time of cord clamping, you see what you're sort of taking out of the picture while you're doing that. And in the last stage, that's really kind of your post-cord clamping sort of physiology and the transition that's occurring. So the important things here is the ductus venosus does carry a large percentage of the cardiac preload, and once we clamp that cord, we do lose some of that preload, which is why it's important to ensure that baby is transitioning successfully. Foramen ovale and ductus arteriosus. So basically what we're doing at that time when the fetus is transitioning is we're going from a circulatory system that is fetal-like and different and transitioning to a more adult-like circulation. And that takes a little bit of time. And really from our standpoint, our resuscitative efforts are really solely to try and assist that transition. So if baby's struggling in any way to go through that process, we're going to take steps that are going to try and facilitate, those shunts closing and switching to breathing air and have an adult-like circulation. It's not truly adult yet, but it's getting closer to it. Right? So, and the overall change that we're doing, obviously, within minutes of birth, is we're going to be aerating the lungs. So we're bringing the lungs into play for the first time. We're going to be establishing pulmonary gas exchange, and we're going to be closing those shunts. So the baby's going to be closing those shunts, potentially with our help, to be more adult-like. So we talk about a number of different things. So the big issue right at the start is that our biggest concern is to adequately ventilate the lungs. And basically, in utero, obviously the lungs are filled with fluid and the baby does breathing movements, but it's all filled with fluid, right? And so basically we have to, during the birthing process, that fluid has to be cleared. If the fluid's there, you can't be aerating the lungs. Simple as that. So there's sort of multiple proposals for how this occurs. And this has a little bit of implications for what happens during deliveries and potentially in deliveries that are either premature or C-section deliveries. So one of the mechanisms is that during the uterine contractions, there's abdominal pressure applied that translates to increased thoracic pressure, which then expels stuff fluid via the trachea. There's also a stress response that's at play, so adrenaline and the catecholamines are released that stimulates sodium channels, which reverses osmotic gradients and causes reabsorption of that fluid across the pulmonary epithelium. And this is where, with C-sections and preemies, some of these mechanisms may be impaired. Right? If you're doing a C-section delivery, you don't have those uterine contractions, so you don't have the abdominal contraction or pressure that is increasing thoracic pressure that's causing some fluid clearance. In premature infants, it's thought that stress response to secrete the adrenaline in the first place is really immature and not developed, and so may not even be active at all, depending on how early they're born. So there's some things to consider. Now, fortunately, a C-section is something that we probably won't have to be doing in the emergency department, unless you're really unfortunate to have the baby born in the parking lot or nearly born in the parking lot and have to come in and mom heart stops and have to do a crash C-section. So that would be if that's your unlucky day, hopefully you're lucky to buy a lottery ticket afterwards, because you're 1 in a million chance. And probably the other method that I think is where we come into play the most during any resuscitation is the lung fluid moving distally through the airways. So basically that lung fluid is thought to sort of move down to the terminal alveoli due to pressure gradients and then get reabsorbed that way. And so when you look at some of these concepts, this is where something like sustained lung inflation, which is a bit of an area of controversy and has been under research for the past few years, comes into play. The thought is that if you inflate the lungs and apply a little bit of pressure for a brief period of time, you may assist with moving that fluid out the terminal alveoli and basically reabsorb. And so there's some discussion of whether there's different things that we could be adding to the resuscitative algorithm in the long run that may improve outcomes. Although most of this research is still pretty early and there's no real clear answers for that yet. So don't be doing anything too crazy just yet. But when you look at the circulatory changes that are going on, obviously the right and left ventricle and the fetal heart are pumping in parallel, and both are contributing to your systemic circulation. And pulmonary blood flow accounts for a very small proportion of the cardiac output, or the RV output at that time, because the vasculature there is just so constricted, right? So very high peripheral vascular resistance, and you ultimately, during that transition, are trying to get that blood flow back into the heart as well after you clamp the cord. So this is where another concept comes up with is delayed cord clamping. There's some question as, well, if we delay the timing of when we clamp the cord, can we provide some benefit or provide some ventilatory support in the meantime that basically moves that transition along a little bit faster before we cut that sort of source of preload that's coming from the placenta? Again, there's no clear answer of what the timing for that could be. It's sort of something that's continually being looked at and may pop up as a discussion point in the guidelines at some point, or in some of the guidelines you see in the future. But at this point, there's no clear answer when or how you should do that. And I think probably in our case, if baby's born in the parking lot, lower the baby so you get a little bit of a blood bolus essentially before you clamp that cord, and then basically, as Chantal was saying, divide and conquer at that point. Unless it's 5 a.m. and it's just you, which makes it more challenging.
But yeah, that's like the one. So in the case that I had, right, like the one benefit was mom was already holding the baby below like her level, right? So there was some already additional kind of preload that baby got through placenta. So in some ways, and generally speaking, most of those are going to end up being delayed forward time, because by the time you get everything ready and stuff like that. So for us, it's probably a moot point when you're thinking about it, because by the time you get it, it's not like you're going to be probably ahead of the game, I would think.
So yeah, I mean, that's not the time to be like celebrating this birth that you had by raising it up like the lion. So the clinical implications to all this, again, is at birth we're trying to transition to this adult-like circulation, get the lungs aerated. And what's probably the most effective way that we can assist this process if we need to? Does anyone have an idea what probably the most effective strategy you're going to use if that baby comes out, you clamp the cord, and now what are you going to do? What's the number one thing you can do right off the bat that's probably going to be the most helpful thing? Yeah, grab a towel and dry them off. That stimulates them, right? And put them in warm, dry towels. And that stimulation will really help that transition period, and about 90% of them will respond to that. 90% may not even need that, but basically most will respond immediately to that and won't be a problem. And then again, and then there's all this sort of academic research into potentially what I view as more complicating issues for everything else. But when do I clamp the cord? Do I do sustained lung inflation? They're nice ideas and they're good concepts, and certainly the research is going into that. But it's not there yet, right? So it's kind of more trying to bring some other concepts to make it interesting and a little bit different from just reviewing the basics. We'll talk a little bit about that as we go on further. So again, our sources for this, NRP, resuscitation guidelines, circulation guidelines, and so on. It's a lot like our adult guidelines. There's no strong evidence to suggest, that EPI's amazing, it works fantastic. It's just, it's expert consensus, right? They review all the papers that are out there, review what's in practice, and try and come up with the best sort of advice for what to do in those sorts of situations. All right. So we'll talk a little bit about the actual sort of the algorithm in a minute. But I do want to try, like, just to gauge where we're at and see whether we should just stop the talk in like 5 minutes or not, and just go through a few questions if that's okay with you guys. So it's on PolyV. You can access it one of the two ways. If you're on your laptop, you can access it in the top way via the web, or if you have a cell phone, you can just text to that number 37607 and put in a message, and then you'll be able to answer the questions.
Just go. Give them a minute, Sean.
Yep.
Go ahead. Just give them a minute.
Oh, sorry. And if you don't know the cell phone, you can just shout it out.
You good?
All set? Yeah. You guys just clicking things? Sorry, so the question is, so 35 weeks, gestational age, quiet cry, reasonable tone, what will be your next steps? That's about it. So I think actually probably would accept both of those answers. I think D is probably just a little bit better because warming is going to be important. But I think both of those answers are acceptable, which is why we have a small chunk there basically going to those. Agreed? Yeah. I'm just happy this actually worked. So we notice meconium staining on a crying newborn. What would your next step be in that situation? Would you suction? Endotracheal tube with suction, place under the warmer and towel dry, provide ventilatory support with BVM, or hand baby to mom. Ask her to clean it off herself. So I think with this one we were looking for, actually would be C in this case, right? And we'll talk about that as we go through it. We kind of suspected that a lot of people might pick suction for that, but those are things that are sort of getting less and less suctioning is going on all the time. And we'll talk about that shortly. So term baby, poor breathing effort and crying. What's your next step in this case? Positive pressure ventilate with oxygen saturation, clear airway, straight on to chest compressions, clear the airway with side monitoring CPAP, and intubate for stimulation plus respiratory support. Oh. I'm getting nauseous looking at this. So the chest compressions is going way down there. I wish I had selected the extra option where I could identify everybody. What's that? So in that one, basically, we're looking for B in that case, right? Basically, want to clear that airway a little bit. Don't do any deep suctioning, and that's going to come up as a theme, because any deep suctioning you do is going to potentially result in a vagal response, which really the last thing you want if an infant is struggling for that transition is to basically drop their heart rate, right? So, or not stimulate them. So that's an interesting one, and we thought we might get a little bit of difference on that. And they're a little bit intentionally, similar in some respects to make it a bit of a challenge for you. Okay, question 4. There's only 9, so we're almost halfway there. So after providing positive pressure ventilation, oxygen saturation monitoring over a minute, heart rate is 77. What's the next step in that case? Do you guys want me to go through each one? Or are you content to read them off the screen? You love these chest compressions. Yeah. Okay, so I think most of you got that one right, the corrective steps. Again, and we'll talk about this, is your ventilation is the intervention that you're doing. Your heart rate is the marker of the success of that intervention. So the first thing you want to do is correct your ventilation, make sure that you've got adequate and good ventilation. Chest compression is a little bit aggressive at this point, and that's, as Gurinder was discussing with me the other day, like that's kind of a more adult mentality, where we're now sort of compressions, airway, breathing, where in these cases it's still airway way before breathing and circulation. Question 5, about 2 minutes post-delivery, despite efforts to improve ventilation, oxygen sats are approximately 60%, heart rate is 53. What's your next step? So if that was the same person just clicking chest compressions all the time, you got it. Perfect. I gave him the answer. 107, wow. I'm pretty sure that we won't get it. Someone throw in something else just for fun. Oh, there we go. Nice. All right. So yeah, I think the audience speaks to the correct answer for that. That heart rate's below 60. Your ventilation, you're over a minute in. Your ventilation has been corrected. You're still not getting a good heart rate. That's when you need to start getting more aggressive, and that's going to happen in less than 1% of the deliveries, approximately. Just to be reassuring. What oxygen concentration do you start with? So this is kind of a weird question, because it's true for A. The guidelines specifically will say that you start with 21%, but really there's a lot of controversy in this, and depending on the source that you read, in these sort of newborn sort of resuscitating emerge situations, you'll get different responses for that. we'll talk a little bit about, there is a little bit of concern with the 100%, but you know, I don't think you'd really be faulted in sort of an emergency situation for choosing any of these. If you went with the 21%, you need to be watching closely and have a very low threshold and start titrating up as you need to. Okay, initial resuscitation efforts went well, baby looks reasonably well, good cry, slight peripheral cyanosis, heart rate 90, what's your next steps there? So again, starting to get that the key is ventilation, and D is the correct answer for that one. Because that heart rate is still under 100, right? So a number that we're more comfortable with, but you know, with the kids, you should be uncomfortable with that number. 10 minutes post-delivery, oxygen sats are 86%, heart rate is 103. What's your next steps now? Okay, that's good. That's kind of what we were expecting. The key to this one is it's 10 minutes post-delivery. And you know, a common, I think, mistake that we'll make as adult emerge docs is forgetting that, you know, a SAT of 86% in a newborn 10 minutes out is normal. You're not worried about that yet. But we'll talk about that briefly. I've pretty much gone through that. And what's the most important marker of resuscitation success? So what's the thing that you're looking for as kind of your target? So heart rate is the correct answer for that one, and that's basically, you know, that's going to be telling you how good your ventilation is going. You're looking at that heart rate is to tell you what's going on there. Okay. So I think that's the last question.
It's good to see that 24% of people didn't actually listen to you 2 questions ago when you gave that answer.
I know. Thank you for listening.
Don't blame you.
What's fast break?
What's that?
What's fast break?
70%, isn't it? So basically, this is, you know, the algorithm we all have. I was talking with Myron yesterday, and he was potentially going to put together just a little card like this. I always think it's just handy to have these. You can buy these; they're easy to get. But one that you could just clip onto your ID badge, so that, you know, even if you're stuck and you forgot to sort of think, oh yeah, I could have a newborn resus tonight, you could at least pull it out and just look at it and be like, oh yeah, okay, it's not really that complicated, right? So we won't go through it in detail. The goal when you see this is always think back to that physiology, right? And what are you trying to do in a newborn resuscitation? Baby's going to be trying to make these changes on their own, right? And in 90% of the cases, things will be totally fine. Towel dry, not a problem. In another 9% or so, they'll respond to just drying and warming and may need a little bit of ventilation. And that's about the other 9%. So that's 99% of them, you won't go farther than providing a little bit of ventilation. And then it's less than 1% where you need to go down towards the bottom part of this algorithm where you're looking at compressions and epinephrine. The key thing is to think back to the physiology and why you're doing the things that you're doing. And what you're doing is you're trying to act relatively quickly because, you know, you have a short time frame to sort of assess whether you need to provide some ventilatory support. So it's not the time to be standing around, you know, sipping coffee and like, holy shit, look at this case we got. This is a good case. Let's call in the resident and the medical student in here. This is the time to sort of act quick, move the baby in, get them under the warmer, and start drying them right away and see how they're doing. If there's any struggling at all, that's when you basically provide a little bit of ventilation. And if there's still a little bit of struggling, you provide more ventilation. You check it and make sure that it's okay, right? And at any point, if your heart rate starts dropping below 60 once you pass the 1 minute mark, that's telling you that there's a problem with the ventilation for some reason, and you need to do something to try and correct that. The first step being correct the actual sort of your mask seal and some of the basics like that. So most babies initially will have a bit of an apneic period. That's probably normal. That's why we're towel drying them. It's kind of like giving baby time to sort of transition It's sort of keeping our hands busy so we don't start doing crazy things like let's get out all the crash carts and EPIs and so on, okay? So towel dry them, put some warm towels on them. If that heart rate stays above 100, you don't really need to do anything for the first 30 seconds. We talked a little bit about the cord clamping business. You know, again, you know, if you look at some of the research on that, there is some support to say that it helps in term infants. There may be increased need for hyperbilirubinemia, phototherapy for hyperbilirubinemia in the short-term period, but in the long term, it seems that there might actually be some benefit in that iron and hemoglobin concentrations a few months down the road are a bit better. But the jury's totally still out on this. Definitely something I don't think you want to try in preemies. Again, just remember to give that bit of a placental blood bolus before you cut the cord. Again, with the breathing, you know, you want to give effective ventilation to keep that heart rate above 100. And if you're having any trouble with that and you're not being successful with that, this is where we go to the whole little Mr. SOPA thing that's in the NRP. Has everyone done the NRP program? Has anyone not done it? Yeah, so few. I think it's a good program. It's very, you know, it's pretty much standard ACLS, but it's great for obviously neonatal resus. But it's good to just run through it. I think, you know, they do lots of sim with you and everything, and it's helpful to do that. But this is one of the acronyms that or mnemonics that I take from it. So if in that initial period your ventilation, you're struggling with that, so heart rate's not coming up or they're still flat, like you know, providing, the thing you want to do then is to check to make sure you're doing a good job at that. Because that's where one of the common pitfalls are. So you want to make sure you've got a good mask seal, and we'll see in a video shortly, those masks are tiny, that can be really tough to do. You want to make sure the airway is in good position. So hyperflexion or hyperextension can include that airway a little bit for you. So put a roll under the shoulders. Suction the nose and mouths, no deep suctioning, but just sort of suction to get any sort of big fluid that's in there. Maybe a little bit of jaw thrust, put a little bit of pressure on the mask to get a better seal. And if you're really stuck, just consider an adjunct, throw in an LMA. Any infant over 30, or gestational age over 34 weeks, or greater than 2 kilograms, you can put an LMA in there and that'll be just fine. It's not a problem doing that. Slight risk of gastric insufflation and aspiration, but if you know, you're better off getting better ventilation with an LMA. If you can't achieve that with a mask, then go for that. And remember those preductal SATs, that was one of the questions that kind of tricked a few people there, is that it takes time for these SATs to come up. And I can guarantee you that most of us, if we're standing 5 minutes into this and we're like, holy shit, the SAT's still only 83%, we're not going to be comfortable with that. We don't like seeing that number on a SAT Pro because the alarm bells are going off all the time and everyone around is being like, you know, doctor, the SATs are 83%, you know, but that's, at 5 to 10 minutes, that's not a big deal, right? That's something that you just continue doing what you're doing, don't go crazy and do some major intervention that's going to derail your whole resuscitation. The sustained lung inflation concept I brought up a bit earlier. The European resuscitation guidelines are actually have recommended a little bit of it in some cases for apneic and preterm infants. And the thought is from some animal research that it improves pulmonary blood flow, cerebral blood flow, improved lung compliance, and improved speed of circulatory improvement. I don't know if we're going to be doing that here now, but I mean, I think if you take a little bit step back and say, well, sort of physiologically, what might be sort of another step that you might be able to do, a little bit of pressure, a little bit of PEEP might help, sort of move that fluid to the distal airways to help clear that. Again, Cochrane review and much of the research says it's inconclusive at this point. So meconium aspiration, obviously this is something that always makes us a little nervous because we hear about it all the time, comes up in the textbooks, the specific interventions we're supposed to do there. And I think what I'm going to try to have you take home with you from this part of it, is that meconium itself isn't bad. If you see meconium, that's not necessarily bad, right? It's poor respirations or poor ventilations that are bad. And if meconium is present in that scenario, then that changes things a little bit. So just because you see meconium, if baby's looking pretty good, don't do anything, right? Just basically do the usual things, towel dry, treat it as if the meconium's not even there, right? It's when the baby is flat and there's meconium is present, that's when it becomes a problem. Because if you have a baby that isn't flat and there's meconium and you try suctioning, things like that, you can induce that vagal response, which is not going to be helpful in resuscitation, right? And
so swallowing or aspirating shit is not bad. As per Sean.
Well, it's bad for things I would not want to do on my bucket list, but I probably did it when I was born, so So, you know, in each of the studies, you know, between 2000 and 2004, each of the studies kind of has stepped away from suctioning, right? Originally, as soon as baby's head came out, it was suction, 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 right? And then basically we said, you know, that's not helpful. And then basically, oh, there's a bit of meconium there, suction, suction, suction. That's not helpful. So each step is sort of moving away from that. And there's actually even been some studies that have shown that even in babies that are flat with meconium, there may not even be a benefit to doing it in that case either. Because there's some studies that show it didn't decrease the risk of death or didn't decrease the risk of meconium aspiration syndrome. So we may see in the long run that we get further and further away from this. For the time being, obviously, flat baby with meconium is still tracheal suctioning, but normal baby or reasonable baby with a little bit of meconium is treated as there's no meconium there and just do all the usual things that you would do.
And, you know, and I think, you know, from a practical standpoint, you know, if the baby's flat, and particularly if the heart rate is low, I think the thought of, especially if you're not used to doing this, suctioning below the cord, so throwing a tube down, intubating the baby, suctioning, and pulling that tube out, and then expecting that you're going to get it right back in again to start ventilating the baby could be a little bit nerve-wracking. So I think that it's very reasonable in that situation if you tube that, and we've had this discussion, I had this discussion with neonatologists a few years ago because we had one where you know, baby was flat, we had to need to do compression, and baby was completely happy. So the question was do you even, in that situation, if it's a non-skilled person, you're not in the neonatal delivery room, you just leave the tube in and continue with the rest of your resuscitation steps. And I think that that would be, you know, most likely well within kind of the standard of care in that situation. Because, you know, I think he's going to talk a little bit about airway, but again, you know, intubating a little 38-weeker, if you're not used to it, is very different. You know, I think we talk about the, you know, cords not looking the way that you expect cords to look. Basically, I always say, look for the thing that looks like the esophagus, but it's not the esophagus, because they look pretty much the same. They're pink. You know, you can see the cords are pink and kind of, you know, it looks like it basically looks swollen, is what it looks like more than anything else. So it's one thing to be cautious about. I think in that situation that'd be totally fair. And that goes to what Sean was saying in the end. Don't get excited about meconium, I think, is the take home there.
We talked about this when the question came up. So basically, you know, the guidelines just say 21% oxygen. The reason why that's a little bit of a controversy is, is we know that some hyperoxia can be damaging too, right? We know this from the adult literature, and you know, there's some evidence that this also can occur in pediatrics cases as well in newborns, particularly in preemies that have oxidative damage. They find some real-world outcomes. There may be delay to first cry, delay in spontaneous respiratory pattern, retinopathy of prematurity, some of the things that seem to be related to exposure to hyperoxygenated environments. Again, when you read different sources, it's going to vary a little bit. I think, you know, a relatively safe way to term babies, start off at the 21% with the air blender, and then, you know, but don't be shy to move that up if you need to, right? And then if you have moved it up high, you know, be conscious to sort of drop it down or titrate it down as you can, because, you know, any prolonged period, there probably is some link to damage that can occur in the long run. You just want to be mindful of that. Again, you know, there's no enough evidence to really state clearly which is one better than the other at this point. And so remember that all this business about the ventilation going on, the most important thing is making sure that your ventilation is working, right, if you're actively helping the child. And in that case, really, that's your heart rate that is basically your pass or fail mark, right? So if your heart rate is less than 100, well, then you still have ventilation work to do. If it's less than 60, then it's really a problem. You need to start the compressions at that point, but still keep in mind that your ventilation is extremely important. And we're discussing kind of the best way to get a pulse on a newborn.
So what do you guys think? Where do you check a pulse on a newborn? Yeah, so the umbilical stump is probably the best thing, right? So, you know, you can check femorals. I don't know if anybody's had a hard time ever feeling a femoral pulse. I freely admit I have in newborns. So, you know, auscultating and feeling for a pulse is probably, auscultating a heart rate and feeling a pulse are probably the two best options that you have. Which, you know, goes against kind of how you normally think about things, right? So.
Even in the adult literature, some of the studies show that docs and nurses about 80% of the time can actually accurately detect the pulse. And detecting the absence of a pulse actually takes a long time, and they're even worse at that. So, all right. The compression is fairly basic. You know, you wrap your arms, your hands around the chest. You're looking for about 1/3 of the AP diameter. The compression rate's pretty fast, so the compression to breathing ratio is about 3 to 1, and you're looking for a total of 120 events per minute. So that's 90 compressions and 30 breaths a minute. So it's pretty quick, right? It was like 1, 2, 3, 1, 2, 3, 3. So you're moving pretty fast in those situations. And remember, unlike us in the adult side, A comes way before B and C in a newborn resuscitation, right? Compressions aren't the saving grace, ventilation is. Vascular access, putting in a central line, if you think you can do that with something the size of a kitten, then go for it. But I suspect that'll be more challenging than you think. Those vessels are really tiny, right? An IO is an option. Again, try to put an IO in a kitten. If you have one at home, try it out tonight. That's what happens, right? It's going to be a hard thing to do. The last thing. I'm trying to make it somewhat entertaining. And the last thing is, your umbilical vein should be there. That's probably your best option. It should be fairly straightforward. There's going to be 2 little dots that are the arteries, and there's going to be a bigger dot that's going to be the vein. You want to put the feeding catheter or something like that down to the vein. Okay? And epinephrine, in that less than 1% where you actually get to this point, don't even think about this until you've had at least a minute of CPR. You've tried, to ensure that your ventilation is adequate, and you're like, yeah, I'm not doing anything wrong with my ventilation. It's perfect. Or you've established a definitive airway, and the heart rate is less than 60. Then you can start thinking about using epinephrine, right? And in that case, it's 0.3 mils per kilo if it's a term baby of the 1 in 10,000. If you don't have access, so you failed your femoral line, which you probably will, you failed the IO and you've gone right through the bone or something, which you might have, you tried all these things and you forget about your VBC, you can put it down the endotracheal tube, but keep in mind when you do that, it's not going to be as effective or as predictable, right? Because it's going into the lungs now, it's mixing with all that fluid that's in there, and it's getting diluted, and you're adding fluid to the lungs, which is kind of the opposite of which we want to do. So one of the suggestions Gurinder had is in that case, if you have whatever, use the 1 in 1,000 instead, so that you're using a much smaller volume of fluid and go with 0.3 mils per kilo down the tube if you have to do that.
0.3 mils.
Right. 0.3 mils, sorry. Okay. So I think now we're going to go to...
There is a problem with that though, and the dead space of the tube will sometimes use most of that drug up. So you have to be cognizant of that, you're not getting a response, and maybe in fact that the volume is too small. And I've seen that on a couple of occasions, right? You've got a 3.5 tube in, the volume of 3.5 is greater than 0.3 cc's.
Yeah, so it's a tenfold increase. So yeah, so that's the one. Yeah, you definitely have to be cognizant of that. I think the giving 5 mils down to 2, and depending on the size of the baby, if their tidal volume probably going to be 5 mils, makes it a little bit challenging. So ideally, that's why they moved away from that, and noticed NRP trying not to give it down to 2. And I think that's important that if you can get access somehow. And I think trying an IO is very reasonable. And I don't think you have to go home and try one on your kitten, but I think it's a reasonable option. But again, not forgetting that you have that umbilical cord there, and putting in a UVC is an important thing, I think, because ideally that's what we want to do.
Go for the big one.
Sorry?
Go for the big one.
Go for the big one, yeah.
The big
Smiley face, 2 eyes, which are going to be the umbilical arteries, and then the big smiley face is going to be the mouth, is going to be the umbilical vein. I think we talked about that a little bit.
Yeah, it's come up here. No animals were harmed in the making of this presentation. The kitten analogy is just, it's small. All right.
So this video, so what we did was a few days ago, we came up here to UH and thought we'd take a look at what is available here at UH and stuff like that. I don't know how many of you actually are aware of anybody know what you guys have here at UH? I told Doran to go and find me a 1 cc syringe, to go find me an umbilical line. What else? I gave him like 3 or 4 things to find. 20 minutes later, he still wasn't there. He was still asking people. So, but it's actually pretty well set up. So we did this so before you guys did any of the rentals and stuff like that, I came up, I think it was about 5 years ago, and we did a neonatal resus kind of, with the resident group, and there was a bunch of RTs there, and a bunch of nurses, and I think highlighted a lot of the potential difficulty with not even our allied health staff knowing where things were. And so, I would say that your nursing staff now I'm hoping, generally are a little bit more well prepared up here, because they actually come up regularly. So one of our RTs and one of our nurses, they come up regularly to do kind of some neonatal sim. So I think most of your nurses probably now at least know where stuff is, which I think would be more helpful. It doesn't mean that Doran knew where anything was, but that's besides the point.
So we'll walk through a little bit about kind of where things are and stuff like that.
Thanks for that.
Okay, so we're at UH first, and just to review kind of where everything is here. We thought in case this happens, it should be good to know where things are. So, first off, yeah, there's a patient right next door. They're cardioverting. Here, where are we? We're in resus rooms. Resus rooms. Okay, so Russell Hart. Which is fine if you have pediatric resusces, but the truth is, from a newborn standpoint, even though there's a newborn drawer here, and you have some newborn equipment like a newborn mask, you do have a meconium aspirator here, you have some small tubes, there's a 2.5, there's a 3.5. What you guys actually have here, which is probably even more important, and I mean, I guess a lot of you probably have no idea you have, is something called the kangaroo board. So the kangaroo board, you guys know that you have this? No? It's fantastic. Kangaroo board, and you have everything that you would need in neonatal resuscitation. So you have umbilical vein catheters in case you need to put in a UVC, peripheral IV stuff, pneumothorax kit. You have drugs, so the only drugs really that you should need, epinephrine, as well as potentially Narcan. So you're delivering a baby, you decide to give the baby some fentanyl. You have some Narcan available. And then you also have all of your airway equipment, so your different size face masks. You have endotracheal tubes at the bottom. So the truth is, you ever have a newborn, don't go to the Braswell cart. Just grab this thing. This thing has everything that you need in it. Even in a small yonder, because most of your equipment, otherwise obviously it'll be too big, right? So this is still starting off to your blades in case you need anything. And extra batteries, breath. So the other thing. If you have a stethoscope, since your stethoscope will cover probably 80% of the body's surface area. So you have a kangaroo board. So really the important thing I think is that if a baby comes in who actually needs anything, open the kangaroo board and bring the baby over to your canvas. So you draft, it's basically depending on what it is. There's a few cobwebs as we took the covering off. I would presume your nurses will know what to do. The only thing that you have to do, obviously, to get rid of, all of this, because know that that's where it turns on. And automatically, when you turn it on, the heater will turn on along with the lights. There's some kind of advanced functions here that your nurses will know that you won't necessarily need to know. So one of the things I was saying, from a preparation standpoint, if there's a delivery outside, tell somebody as you're going out, turn the warmer on, so that way it's on and it's ready to go when you come back. Not that this is really probably all that important. And then you can go to baby mode, and it'll set the temperature, 36.5, and there's a temperature probe that goes on the baby. You want to set your timer, which is always nice. You just set your APGAR on off, and your timer will be going automatically. And of course, since it's on baby, it's reading off that it's cold. The other thing that you have on here is you do have a flow inflating mask along with your oxygen blender. Okay, so you do have a flow inflating mask, so the mask attached to the Panda that you can turn off. And the nice thing, obviously, about a flow inflator is that you can provide some PEEP as well when you have a good seal. So, some of the babies may just need some PEEP, so just providing a little bit of CPAP as well could be of some benefit. Okay, so Doran also wanted to go over some of the equipment. So, first thing for me was fascinating just looking at the size of the neonatal mask. You forget how small babies are. Just to remind you, size of the mask, trying to ensure that we have a good seal. So you guys actually have here at UH, you have a preemie mask as well as a term mask. So again, the usual airway positioning things for a baby, you want to roll under the shoulders. Trying to remember not to hyperextend either. That's a common error when it comes to babies.
proceed with the intubation, if you are intubating. Then you remember, so they're going for the pearly white gates in the baby. Remember, the airway and the cord will look very pink. So you're going for the thing that looks like an esophagus, but is not the esophagus. That's really what they're going to look like. So even the cords are very pink and often quite round, look very similar. We also have the meconium aspirator in case there's meconium and the baby is flat. So the meconium aspirator, as far as kind of how this hooks up, basically you take the rib head, and that goes into your suction. Okay, you attach your endotracheal tube to the larger end. Once that's done, so you intubate as you normally would. Once it's intubated, so hook this up beforehand, intubate as you normally would, and then you attach this end, the larger end of the aspirator, to the end of the endotracheal tube, so the adapter on the endotracheal tube. And then you just occlude the suction port and withdraw the tube. Okay? Yep. You also have a pneumothorax kit, so so this is also part of the kangaroo board. So we figured we'd go through that as well. So for the pneumothorax kit, again, thinking of how small these babies are, if they pop in the way that generally speaking, you would take care of that. Instead of placing a chest tube early on, you needle the chest, just with a little butterfly actually. Once the butterfly is in, you take the end of the butterfly, attach that just to your sterile tubing, and you place the end of the tubing in the sterile water, and that then provides your underwater seal, and that'll work, for a temporizing measure until you can place a chest tube, which obviously the neonatal transport team would do, but as a temporizing measure, that would do the trick, and often you can do that in actually for a day, and it's not an issue. Okay. So access-wise, we also have an umbilical catheter set. So let's open it and see what you guys have in here.
Oh, we have a checklist.
Oh, that was for Samara. So, little line kit. You guys have a whole bunch of stuff here, but the most important things really are, first step is to take a tie, so whether it's the umbilical tape or just a packing tape basically, and you want to put a tie at the base of the umbilical stump. That way, in case you have accessibility, you can just tie that off. Then you're going to clean the dog with your chlorhexidine swabs. The one thing in here you don't have is any forceps. So you want to hold some forceps at the top. Clean cut with your scalpel, which you guys have right here. Clean cut through with the scalpel, and then your umbilical line goes in. You have an extra line as well. You aim for the space of the smiling face, right? So as a reminder, 2 umbilical arteries, 1 umbilical vein goes into the vein, thinner wall, usually longer. Vein goes in. Once you have blood back, flush, and it flushes well, you have a line that's accessible. So for some of you, the only line you replaced were potentially in PCC or PCC when you were residents. There was a whole measuring thing, how long to do the line. None of that applies here for a resus line. It just goes in. Once you have blood back, you can use it, and as long as it flushes. So, one of the things that we thought we'd go over is giving the epi. And the reason is that although generally speaking we're really lucky, right? If you ask for drugs, nurses can give it, not a problem at all. The epi, just because the volumes sometimes are really small, it's a little bit difficult sometimes if people haven't done this regularly. Because we're not going to give the usual, hey, let's give an amp of epi to a 2-kilo baby. So I'm going to walk through kind of probably the easiest way to do this, because your nurses actually may not know this. So have our epi, of course, just like as we normally would. All the yellow comes off. And once you have it like this, easiest way to do this is actually to grab a 3-way stop cock. You got 3-way. You take a 1 cc syringe. And now you can just draw it back how much epi you need.
to give 0.3 cc's, you can actually give 0.3 cc's. Because otherwise, as you can imagine, trying to give it without a three-way stop clock and try to figure out where your 0.3 cc's is, with that syringe is going to be very challenging. So it's something that, people often aren't used to doing. But one of the things that is probably the easiest things to do if you're giving epi in a resuscitation for a baby. So the most important thing to remember is, first of all, if you have a precipitous delivery here at UH, almost invariably the baby's going to be wet. Babies tend to be born, precipitous deliveries are usually ready for the real world. But the most important thing from that standpoint, if the baby's born outside, is that we need to warm the baby, dry the baby, stimulate the baby, and if at most, you probably shouldn't need anything more than just anything baby. So if the baby does come out, looks great, remember to stay calm and do those first few steps. Done.
Okay, so there's only a couple things at the end, but I think we're going to skip over those. Basically, I hinted about most of this throughout the presentation. There's a couple things you may see in the new guidelines. There won't be any major changes, we don't think, but just so you know what they're talking about in terms of these SLI and DCC and things like that. And how to stay fresh. It's basically one of these things. Just keep in mind you can do this at any time. Review it, sort of think about what you do in that situation. I think from the presentation at UH, the kangaroo board has got everything on there, and all of the stuff you need for each of the steps that you might have to do, as you can see, are all bagged in little kits, so it makes it very, very simple and very, very efficient. There is a sim program for this that Myron and I think Samir is involved with, where they're doing, you can sign up and do some resuscitation with newborns as practice, not real ones obviously, but to practice doing that. And, the NRP is a good program. That's another option that's offered quite frequently here at Victoria Hospital. So with that, just thank you for coming. If you want any of the articles and stuff, I can link it to some of those in my Dropbox. And, if there's any questions, I don't know how much time we have. You go ahead. Okay. Yeah, no.
I think the other thing I was just going to say about the warming and drying, I didn't mention, I thought, just as a reminder, and again, it's, most of the kids, if you ever have, they're going to respond to that, which is fine. But the one thing to remember, and it may sound silly, when you dry the baby and whatnot, and you have those wet towels, take the baby out of those wet towels and place them on warm towels. I saw that more than once when I was a resident doing transport, where we went somewhere and the baby was wrapped, and they thought they'd done the right thing, and they obviously did their best, but baby's wrapped in the same towels that they initially dried the baby with, so baby's lying in cold towels, and so that's one thing to remember, that when you dry, get rid of those, get some new ones, keep the baby warm. Like I said, generally speaking, the baby's going to be okay from that standpoint. If not, a little bit of bagging should turn the corner. And like Doran said, the kangaroo board has everything that you need, and the algorithm's posted there at UH as well. And I know the neonatal guys are trying to get kangaroo boards at all the regional hospitals as well. So for those of you who work outside of here, outside of LHC in the region, most places, I know they haven't gotten everywhere, but they're trying to get those everywhere. That's it. Questions? Comments? I don't know if you guys, Gary, Tim, Naveen, you guys want to add anything? I'm going to say that nobody's ever placed a UV. When Tim runs apples, he usually gets some stumps, and you still do that, right, Tim? And you get an opportunity to actually place a UV on a real cord. So for those of you who have never done that or are interested in doing that, speak to the good Dr. Lynch. I think that's it.